Hello, my name is Roxana Mehran from Mount Sinai Hospital in New York, and we're here in the beautiful city, Paris, at the EuroPCR 2012. And it's my pleasure to welcome you to this editorial discussion, Antiplatelet Therapy and Unplanned Treatments. What are the options? I'm joined by my friends and colleagues, Dr. Tony Gershlick from the University of Leicester in Great Britain, and Dr. Alex Abizaid from the Cardiovascular Research Center in São Paulo, Brazil, and Dante Pazanese Hospital and Medical Center. Welcome.
Thank you.
Thank you, Rox.
So we've gathered today to talk about some difficult questions, dilemmas with dual antiplatelet therapies in our patients. Questions probably that we face every day as clinicians, yet there are really no true clinical trials or clinical data behind them to answer the questions. In fact, there are no guidelines on what to do in some of these dilemmas that come up on a daily basis in clinical practice. So we're gathering today, and I thought it would be a good idea for us to kind of have a little discussion about that. So the first question that I have for both of you is, what are you doing when you have a patient on dual antiplatelet therapies in whom a stent has been placed and that patient requires surgery? First, what do you do? How do you assess the patient? And I'm going to start with you, Tony.
Yeah, I think it's such an important topic because it is based on clinical expertise and experience. And my first thoughts about this are that you should try and prevent it happening. So every now and then you come across a patient who's going to need a bladder biopsy or some procedure coming up in the future. And it's very important to take a really good history, because if you miss it, then you end up putting a drug-eluting stent in because you think you've got better efficacy, and you result with 12 months, ideally, of dual antiplatelet therapy. So in those patients, I will put perhaps a bare metal stent in, so they require only 1 month of dual antiplatelet therapy. So that's the first thing. If the situation does arise that a patient needs surgery, then I really want to know that it's required, that they stop the dual antiplatelet therapy. So my big thing is that what are the risks of continuing the dual antiplatelet therapy in such a patient versus the risk of stent thrombosis if we stop the dual antiplatelet therapy. So first thing is communication. So everyone in the area where you work with your hospital, surgeons, general physicians, should know that patients are not allowed to stop dual antiplatelet therapy unless there's a discussion with interventional cardiologists. You then have to have the discussion. For me, the discussion revolves around, do you really need to stop the dual antiplatelet therapy? And I think there is a sort of consensus amongst those who don't know that you should stop the dual antiplatelet therapy, whereas often you don't need to. So you're balancing the risks of a little bit of bleeding versus the risk of stent thrombosis. So that's my first thoughts about what I'm doing. I'm making sure that I know the patient doesn't need significant procedure, and if so, I put a bare metal stent in. And furthermore, every patient has in our hospital a card that says they're on dual antiplatelet therapy, they need to contact the interventionist, and then we'll enter a discussion.
So suppose the patient has a drug-eluting stent, they need major surgery, and it's 3 months after their drug-eluting stent placement in the left anterior descending artery. What do you do, Alex? How do you think about, is the type of stent matter? Do you think about that? Tell me what you do.
Yeah, I think it's an important question. I think that now we're more and more convinced that with, for instance, new generations drug-eluting stents that has fully bioabsorbable polymer that releases perhaps a drug in the first 30, 40 days and then gets dissolved in the next 6 months or so, I'm a little bit more confident, I have to say, that to stop dual antiplatelet therapy before 6 months will be safe. But again, without great evidence. I think that the protocol that we try to follow, Roxana, is that, for instance, if there is a major surgery that is planned, we follow the guidelines of 5 days, stopping either clopidogrel, prasugrel, or ticagrelor. The good news now is that most of the surgeons are now accepting to operate these patients with aspirin. And in a high-risk patient, let's say for stent thrombosis, in these 5 days, we try to keep the patient in the hospital, perhaps with low molecular heparin. So this is,
so we're
again,
going to come
empiric.
to bridging.
Yeah.
I do want to talk about that, and when do you feel uncomfortable? But does the type of surgery matter? I mean, you know, there's a biopsy, there's a dental procedure, and then there is a colon resection or spinal surgery. I think those are important things to consider, right? I mean, if there's someone having spine surgery, the need for stopping the dual antiplatelet therapies would become more paramount than a patient who's having, let's say, a colonic biopsy, for example. But having said that, I think the most important thing that we need to do is educating our peers regarding the importance of dual antiplatelet therapies, when you can and cannot stop them, and consultation, as you said, with the clinicians regarding the patient's status, their bleeding and ischemic risks. So that would be, I guess, one of the things to...
I mean, the real issue is that they have to convince us that the patient's life is threatened more by the bleeding than the stent thrombosis. And of course, the old adage of bleeding within a closed space counts here, so neurosurgery, spinal surgery, say, but there are lots of procedures I think can be done on aspirin, certainly, maybe even dual antiplatelet therapy, where a little bit of bleeding is not the same as a major infarct, which carries a 40% MI and mortality rate.
Yeah.
I mean, certainly our cardiac surgeons have learned how to deal with patients who are on a lot of antiplatelet and antithrombotic agents, and they're able to kind of get through the surgery and do well. There is some association with bleeding, and I think there's this balance, right? And one needs to do this. And this weighing the risk-benefit, it becomes a very, very important thing. You came with a great understanding up front to before you do the procedure. Really weigh it back and forth. But the truth is, Tony, that a lot of our patients are they're older, they have more risk factors, they have many, many other comorbid conditions for which they will require, and this will happen even if you're thinking ahead of time for someone to have surgery right away. So tell me how you weigh that risk-benefit of bleeding and the type of bleeding, et cetera.
Okay, so you've created a scenario whereby a patient, I'm told by a surgeon, does require, they will not do this procedure. The patient needs the procedure, number one. I would ask them to delay the procedure if possible. At least 6 months, and maybe a year, but at least 6 months, because there's good data from Antonio Colombo that the stent thrombosis with discontinuation decreases after 6 months. So I would say to them, first of all, please, can you delay this operation? Maybe a year, maybe 6 months. But if they say, no, it's got to be done, then I think this is the core of this question. And I think that most of the time I do what Alexandre said, which is to stop the clopidogrel. I'm not so sure about ticagrelor because there's some confusion about the reversibility, but I guess if we stuck with the rules and said stop the thienopyridine or its equivalent 5 days before, then that would be the right thing to do. What I do then, I am less clear because there's some small data that suggests the small molecule 2B3As, the synthetic small molecules, tyrofibam, for example, can be started until 4 hours before. And of course, there's the recent cangrelor data that's published this year. So what do? I say, do you definitely need to stop it? If yes, then okay, then I'll stop it 5 days before. I'm not so sure about the data on low molecular weight heparin. But,
so let's talk a little bit about the bridging therapies. Now there are lots of choices. It's almost like a menu of different anticoagulants that one can use. What do you do? And you talked a little bit about low molecular weight heparin, or even intravenous heparin. Tell me, how do you handle that? You said you would bring a patient into the hospital. Now, again, we want to make sure that our audience knows that there's no real guidelines. We're not really referring to any specific, pretty much every hospital and every clinician has different algorithms, if you will. But tell me what you're doing at Dante Pazzinesi.
Well, first of all, I would like to highlight again the importance of knowing the history beforehand. Because now, at least in my geography, in Brazil, we have several new generation stents to choose from. So polymer-free, bioabsorbable polymers, and even the data suggests that with Endeavor, which is an FDA-approved stent, with zotorolum eluting stent, there is a chance, or it's theoretically a little bit safer to stop before. So if I have a stent like that, Roxana, even a little bit before 6 months, I wouldn't say 30 days or 2 months, but a little bit before 6 months, I would be safe to stop it without any particular bridging. unless if that patient is a diabetic patient with multivessel disease, left main bifurcation, there is a little bit higher risk for stent thrombosis, right? Right now, I don't have Angiomax yet approved in Brazil. So what we generally do, and again, in a patient that has an early need for surgery or major surgery, and I probably would keep, as I said before, keep this patient in hospital for 4 or 5 days, and give low molecular heparin, and keep the aspirin if the surgeon accepts. This is also a very intense discussion with the surgeon.
And then how do you manage the surgery around the low molecular weight heparin? Is it again the same, like 8 hours?
12 hours, 8 to 12 hours
beforehand, because of the half-life of the drug.
Exactly.
You stop and then you allow the surgery to occur.
Operate. And generally, we resume immediately after surgery.
You resume, what do you resume?
Well,
low molecular weight heparin, or do you resume dual antiplatelet
therapy? If the patient will remain intubated for a long time, let's say 48 hours, probably low molecular heparin will be indicated for this, let's say, window. And then another loading dose of tenoperidine, and then
So just to summarize, so that our audience, and I want to make sure that you guys agree with me. So not in every case do we need to stop both thienopyridine and aspirin, and if you can, you want to keep the aspirin on board.
Absolutely.
Unless, so that's rule number one, right?
Yes.
Unless it's some closed space surgery, as we talked about, like intracranial, intraspinal, those kinds of things that could have huge ramifications if there's bleeding, as far as paralysis, etc. So that's number one.
Yep.
Number two is that when you're thinking about bridging or not to bridge, you think about when is the timing of the stent, whether it's a drug-eluting stent or bare metal stent. Anything in the first 30 days, whether it's drug-eluting or bare metal stent, everyone's a little bit uneasy, right? But with a drug-eluting stent, beyond 6 months, do you bridge? No bridging.
I think it's a really interesting point that Alex has brought up. I mean, the data based on low molecular weight heparin, of course, is the valve data with warfarin. So it doesn't really pertain to our stent, which is very platelet-centric. So, you know, I have anxieties about that, but I don't have anything better to offer. So I guess we do a similar sort of thing. And yes, we do use low molecular weight heparin, but as I say these words, I don't have any evidence or data to know whether or not what we're doing is correct. Just consensus, which is not always necessarily
So for us at Mount Sinai, we actually, in the patients that we're absolutely very worried about, we do use the small molecule 2B3As as bridging. We are very much anxious to see Cangrelor. The bridging data is very exciting about Cangrelor that Dominic Angelulo presented in the last TCT that I'm sure you've all seen. And I think it's a very, very interesting way of thinking about bridging patients to surgery with this very, very short half-life agents. And Cangrelor is the one that we know would work. We also know in the pipeline, I don't know how much of this you know, is a factor IX inhibitor, which is a Reg1 with an aptamer that has the ability to be reversed immediately. And I believe those could have very important implications. They're still not yet approved. They're in the pipeline. Phase 2 studies looked great, and I think there's a phase 3 coming out. So a lot of excitement in that era.
Yeah, I mean, I think we must be careful here. You know, we shouldn't be using agents that may cause the bleeding, spontaneous bleeding in a lesion somewhere. So we have to have this conversation with the surgeon again. I think the Cangrelor is exciting. We do need reversibility, and it is predicated on the small molecule, the eptifibatide, tirofiban type molecules that have been used, stopped 4 hours before. And there is some data out there. If you look up the data, there is some data that suggests that using such molecules, certainly Cangrelor, this very small study, of course, that's just come out, but certainly for the small synthetic 2B3A inhibitors, there is some data there that says you give the standard dose and then you stop 4 hours before. But we do need a big study. There's absolutely no question about it. The trouble is these patients, when you distill them down, they're very heterogeneous. They don't fall into the same basket, so it's really difficult to do a study, I think.
That's right. And I think the big point is that at the end of the day, how often do we actually need to bridge our patients? And I actually think that we spend a lot of time thinking about bridging, making phone calls, what could be the best thing to do for these patients. We're so worried about them, but in fact, stent thrombosis is quite rare. It really, of course, an extremely catastrophic event, but as we know, there was a recent editorial that basically talked about maybe we hardly need to bridge in many of the cases, and now with the safer drug-eluting stents, as you discussed, we may not need that at all.
One of the things we have to say to this audience is that the negotiating conversations must be, can you delay this procedure? There's data out there to say it should be 42 days. We talk about 6 months. And if you have that conversation, say, if this is not a life-threatening procedure, can you delay it? And then some of these newer drug-eluting stents really come into play.
Yeah, I totally agree with you guys, particularly with Roxana when she says that bridging perhaps is not the biggest challenge, because generally it's as you say, it's a holiday, and then it's short to interruption, and generally these patients are in a very watchful situation because they're close to us, perhaps in hospital, the surgeons is on board, and everybody is really aware that this is happening for the next, let's say, 5 days, 1 week. My biggest challenge, Roxana, is when you have to stop doing antiplatelet therapy for a major bleeding. Let's say a patient that has first generation or perhaps high risk for stent thrombosis and has a hemorrhage or GI bleeding. So that to me is the most challenging situation.
Well, and that particular scenario is sort of almost like a spiraling down of one thing leading to the next. The bleeding begets you to stop the dual antiplatelet therapies, which then puts the patient even in a much higher risk of thrombosis. And this is a very, very big, and we've shown data that GI bleeding, especially GI bleeding or non-access site bleedings, is much higher association with these ischemic complications such as death and myocardial infarction.
So what do you do in Mount Sinai? You stop both when you have a GI bleeding?
Well, we try to go very, very quickly and deploy what needs to be done is all of the GI medications. We bring in the gastroenterologist that will do some cauterization and local therapy to the bleeding ulcer that's actively bleeding. And then we actually try not to stop depending on where we are with the dual antiplatelet therapy.
I mean, this is such a good point because we're about to publish a case history of a patient who had a GI bleed. We got the gastroenterologist in. They did an endoscopy. They put 2 clips on. With a fellow available. The patient didn't turn a hair, an end STEMI, and didn't stop the dual antiplatelet therapy at all in the patient. So you sometimes, direct action can actually stop the bleeding.
In this situation, probably you do the opposite. We stop aspirin and keep thienopyridine.
Thienopyridine, because aspirin is really very potent, isn't it? The other very important piece that I think the audience should know about is that a lot of these choices are very much dependent on the type of patient and the type of procedure that has been done. You talked about the diabetic patient, and you talked about a patient with left main stenting or bifurcation stenting, multiple stenting. There's also the patient with low ejection fraction. Those are the kinds of patients who one really needs to. Are there any other patient characteristics that make you more nervous about stopping the dual antiplatelet therapies?
Well, as a matter of fact, I had one case last week that had high platelet, very high platelet numbers. So that patient, I have to say, that concerns me, and that's something that we generally don't pay attention. How often do you see, the pre-intervention?
So very much inhibited, so that they're like there's 0% platelet reactivity. So you're worried that they're actually at a higher risk for bleeding, or the other way around?
The other way around.
I see.
I think the other way around. Both ways, actually.
So in a patient in whom you feel they're resistant to clopidogrel, you're worried that not so much about the clopidogrel or what have you, but that they're more prone to thrombosis.
To thrombosis.
And so
that's something that we generally
that.
Don't pay attention. But I had this patient last week, and as a matter of fact, he had stent thrombosis. So I think that you have to be, particularly worried in those patients when you have to stop for some reason.
No matter how we cut this cake or take a look at this, these data, that we know that premature discontinuation, and whatever that is, premature for the stent, premature for the patient, is associated with adverse events.
But
right?
that's exactly why you need to be absolutely sure that the patient needs the procedure, and absolutely sure the patient can't have the procedure delayed, and absolutely sure that the patient definitely needs to have the dual antiplatelet therapy stopped. There's good data out there on hazard ratio for the risk of stent thrombosis, and you could tick off the list all the patients that Alex has said, left main stem, diabetic,
multivessel,
multivessel. Those patients, one should be even more
cautious. It would be wonderful, Roxana, you developed so many scores for renal failure, BARC, etc., to develop perhaps a score for high risk for stent thrombosis and vellus bleeding. So in advance, we know perhaps, and it helps us to select our stent first, and then to be perhaps less worried if you have to stop prematurely.
So this is I think, where we need to kind of come in and talk a little bit about what the future holds for this, because it's very difficult to, as you can imagine, with the current situation of healthcare and industry funding and everything else, to actually perform these kinds of clinical trials. In fact, we talked about this of a holiday study where you would stop the dual antiplatelet therapies after a certain period of time, maybe after 6 months, for 3 months, and just to see what's happening with the patients, so that you could get some level of confidence for the clinicians to say, yeah, in this type of a patient, I can stop the dual antiplatelet therapies. How do you think we have to design our clinical trials? When I powered that study, I needed 25,000 patients for the 3-month period. How do we do this? It's daunting.
It's interesting that Alex brings up this idea of scoring. The Prestige project, which is a big European project, one of the aspects, so there's multiple aspects of stent thrombosis, one of them is to design a scoring system, registry and scoring system for patients with who may be at higher risk of thrombosis. So you would actually have one of your type of scores where you would have a number that you would have to the patient. Designing trials, I think this patient group, I think, are very difficult. They are very heterogeneous. I sometimes wonder whether OCT would have a role here. So patients come in and we definitely need a procedure, and we don't know what the coverage is of the stent with OCT. So probably not endothelial cells, but you might think you might do an OCT and say, okay, the stent is covered, you feel a bit more confident. So that sort of study.
So that makes me nervous, because I feel like that we're using this very high technical, yet highly sensitive, I would say, but maybe no correlation, or some correlation. We really need large pools of data before we could make those kinds of suggestions. But I think it's very interesting to think about those technologies in predicting events and helping the clinician to make a decision. But I think what we've done today with this lovely conversation, and I thank you both for being a part of this, is to really talk about the dilemmas that we face as clinicians every day, and our audience really does want to know what you as experts think about and what you do. And it's unfortunate that there's not a body of evidence to help guide us, but what we do know is that we use the patient's characteristics, their baseline characteristics and comorbidities as a very important piece. We weigh the risk of bleeding versus stent thrombosis. We then think about the procedure that the patient is having. Can it be delayed, as you said, or is it an urgent versus emergent versus elective procedure, so that you can think about the timing. And then regarding bridging, it's probably in the rare patient or less common patient that most patients perhaps may or may not need bridging. And if it does happen, there are all sorts of different regimens for which there are no real clinical data for. But I think we covered a great deal of great discussion. I thank you both for being here. And I'm hoping that the future trials and the future drug-eluting stents, as you discussed, with shorter duration of dual antiplatelet therapies will allow us to be able to expand and send our patients for non-cardiac procedures. So thank you again for being with us.
Thank you.